So, good morning or good afternoon, everyone. Welcome to our first NIA dementia webinar for 2026. And this year's theme is really focusing on thinking about the dementia care journey and thinking about our care systems and our care providers. And so, we're really excited to kick it off with you today. Before I introduce the topic and our speakers for today, we just have a few housekeeping notes that we'll go through. So I just want to, again, welcome everybody and just want folks to note that all audience members' microphones have automatically been muted. If you have any questions, though, for our speakers, please use the Q&A box at the bottom of your screens. So you'll see in there you can actually type your questions, and then we will be able to see those and ask them accordingly during the Q&A section as well. If you have any technical issues, you can also let us know in the chat box that's at the bottom of your screen as well. So those are the housekeeping notes, and thank you again for joining us. So just before we start our webinar today, I just want to provide a land acknowledgement. So the National Institute on Aging is based in Toronto, which is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So again, I want to welcome everybody to our webinar today. It's called Rethinking Dementia Care and How Primary Care Providers Can Lead the Diagnosis and Management of Dementia. And as I mentioned a little bit about a minute ago, this year our series of dementia webinars, there'll be 4 in total, are focusing on looking at our dementia care systems, but also our care providers. And so I think it's only fitting that we lead off today's talk by focusing on our primary care system and how we can really leverage our primary care systems and providers to better support the diagnosis and management of dementia. Today, I'm going to be moderating this webinar, and my role as Dr. Sinha, Director of Health Policy Research at the NIA. I'm really proud to introduce the 5 people who will be speaking with us today as well. I'll just go through and quickly introduce them, and then I'm going to hand it over to Michael and Linda to kick us off as well. The first person I want to introduce is Dr. Linda Lee. She's the founder and the executive director of the Mint Memory Clinic. Dr. Lee is a care of the elderly family physician. She's an associate clinical professor at McMaster University and the Schlegel Research Chair in Primary Care for Elders at the Schlegel University Waterloo Research Institute for Aging. She's the founder and executive director of Mint Memory Clinic Model, and she's helped establish more than 130 Mint Memory clinics across Canada and is a nationally recognized leader in dementia care innovation. The next person I want to introduce is Dr. Michelle Casey. She's a family physician with over 15 years experience. And Dr. Casey helped bring the first Mint Memory Clinic to New Brunswick and brings a frontline primary care perspective to dementia diagnosis, long-term care, and medical education. Adriana King is the manager, support, and navigation for the Alzheimer's Society of New Brunswick. Adriana leads person-centered support and navigation services for people living with dementia and their care partners, emphasizing practical guidance, compassion, and community-based care. And then we also have Michael Lee. He's the managing director of the Mint Memory Clinic. Michael Lee is a non-profit strategy and planning professional. He has extensive experience in operations, finance, and planning in the not-for-profit sector. And Michael brings a system-level lens to delivery and sustainability. And finally, last but not least, we've got Sana Adi. She's the engagement director for our Mint Memory Clinics. And with a background in public policy, health administration, and end-of-life care, Sana offers insight into how policy, community care, and lived experience intersect in dementia care planning. So with our introductions out of the way, I'm now going to hand the floor over to Michael and Dr. Lee to lead us in this presentation. That'll include everybody else I just thought, and I'll meet you back when we do our Q&A session as well. Just a quick reminder, if you have questions that come up, please put them in the Q&A section at the bottom of your screen. And if you have any technical questions, please connect us through the chat function as well. Okay, over to you, Michael and Linda.
Perfect. Thanks, Dr. Sinha. It's really a great privilege and a pleasure to be invited to speak today. I'm Michael, and I'm the Managing Director at Mint Memory Clinic. Before we begin, I just want to quickly acknowledge that our main office is located in Kitchener, which is on land that is part of the Holoman Tract, which was set aside for the Six Nations of the Grand River. Though I am coming from Toronto, which, as Dr. Sinha had mentioned, is covered under Treaty 13 with the Mississaugas of the Credit. And I always like to mention that Toronto's motto is diversity, our strength. It's the current home to many people from diverse Indigenous nations and people from different ethno-cultural backgrounds from around the world. We are entering a new era of dementia care, and particularly in how Alzheimer's disease is diagnosed and managed. I think it's perhaps most aptly put by this Scientific American custom media article's title, that there has been a seismic shift in Alzheimer's. Since it was first characterized over 100 years ago, there have only ever been symptomatic treatments for Alzheimer's disease. But now, in Canada, the first potentially disease-modifying therapy for Alzheimer's disease was approved for use this past fall, and it was administered to the first person in Canada just 2 months ago in January at Sunnybrook Hospital here in Toronto. And this and related anti-amyloid therapies are really just the tip of the iceberg of the potential therapies to come that may indeed change the course of disease. There are now blood biomarkers that are available in Canada, and these can help to more precisely diagnose Alzheimer's disease, and they will revolutionize the way that we detect Alzheimer's disease, particularly at the earlier stages of disease. And finally, there are now innovative approaches to dementia care in Canada, which brings us to our presentation today. Our presentation is going to share more about a Canadian innovation, the Mint Memory Clinic model. The Mint Memory Clinic model is disrupting dementia care with an innovative, integrated, multidisciplinary approach to dementia care in primary care. And as put by the Canadian Medical Association in 2019, it is the shake-up dementia care needed. We are a not-for-profit, and we build capacity for high-quality dementia care through standardized nationally accredited training in primary care in collaboration with specialists in community care. Through our training program, we help teams in primary care develop and operationalize memory clinics using the Mint Memory Clinic model. These clinics provide publicly funded, timely access to skilled teams that can comprehensively address needs associated with declining cognition. The model is an efficient shared care model that works with people's primary care providers and integrates collaboration with specialists and community partners. To date, the Mint Memory Clinic model has been implemented in over 130 sites across 7 provinces in Canada, which has included the training of over 500 family physicians, over 1,500 allied healthcare professionals, who are all supported by a network of over 65 leading specialists in cognitive neurology, geriatric psychiatry, and geriatric medicine. And now, with that context set, I'll pass things over to Dr. Linda Lee, who is the founder of Mint Memory Clinic.
Thanks so much, Mike. New models of dementia care are becoming increasingly important because the numbers of seniors is increasing. 10 years ago, Canada reached a milestone where, for the very first time, the percentage of seniors exceeded the percentage of children, and that percentage continues to increase. It's estimated that by 2031, 23% of the Canadian population will be aged 65 years and older, senior citizens. So about a quarter of Canadian population will be over age 65. But what a lot of people don't realize is in that group, people over age 65, about one quarter of them will have some form of memory loss that is beyond normal aging. So we look at conditions like dementia. The prevalence in this group is about 8 to 13%, depending on what you read. And you look at the prevalence of mild cognitive impairment, which for many is a pre-dementia state. Many of those persons will eventually develop dementia. The prevalence in this population is about 17%. So if you add that up, you have about a quarter of one quarter of the Canadian population who have some form of memory loss that's beyond normal aging. And that's going to have huge healthcare system impacts because these people will be approaching their primary care clinician wondering if their memory symptoms are normal or is there actually something more than normal memory loss happening. And I would say that our system is not prepared for this. Next slide. Dementia affects not only the individual and the family members with its own impacts on memory, but it also affects the other medical conditions that person might have. And many consider dementia to be the keystone health condition because it can destabilize the other complex health conditions a person has. And by those, I mean, these are the complex medical conditions that many older people live with, such as heart failure, or chronic obstructive pulmonary disease, or people that are at risk for falls and have hip fractures. What we know is that dementia or mild cognitive impairment affect about a third of these persons. And these conditions are complex because they have often complicated medication management that's necessary. Medications have to be taken regularly through the day, sometimes the way they're administered, such as with the inhalers that people have to use on a regular basis. But more importantly, they require self-monitoring. A person needs to be able to monitor their health status and be able to seek medical attention if their symptoms are getting worse. If a person has dementia, it affects their functioning and it may affect their ability to take medications on a regular basis and their ability to self-monitor and self-manage. And what happens then is destabilization of these other conditions people have. And as a result, next slide, they end up in the emergency room in medical crisis, and many of them get admitted to hospital. Oftentimes, dementia is diagnosed late in the course after these health destabilization events, after their health has deteriorated. And we all know that hospitals are not a good place for anyone, but particularly older persons. The just being in the hospital or the illness itself can actually worsen memory with delirium, which may improve or it might not improve. So people end up often with worse memory conditions and often deconditioning after hospitalization. And it's a very reactive system that we have. That is, it's about trying to help these persons after these health crisis events. Whereas what we need is a much more proactive system where we can diagnose, identify people with early stage memory loss and support them better. If they need more help in making sure that they're taking their medicines appropriately, or if they need more supports and services to prevent these health stabilizations, then we can maybe avert some of these healthcare crises that have such impacts on older adults. So there's a need to change the system from a very reactive system with late diagnoses to a more proactive system where people are identified much earlier on with the aim of preventing these health destabilization events, allowing individuals to live in the community, out of hospital, out of long-term care for longer with best quality of life. Next slide. Here's what happens in usual care. This is a study done of Ontarians. This is published in 2020, looking at about over 100 individuals who were newly diagnosed with dementia. And what they found was at the end of 5 years, only 1/4 were actually living in the community. 55% of them had died. And in that course of 5 years, half of them had transitioned into long-term care. So this is the state of usual care, and why new ways of identifying dementia and mild cognitive impairment earlier on, and also potential for new treatments, why that's so exciting. Next slide. Part of the problem is the detection rate being very low in primary care. There are studies, including the study done worldwide, that suggests that 62% of the 62% under detection rate of dementia, meaning that almost 2/3 of people living in the community with dementia are actually not detected. And the numbers are likely higher for those with earlier stage memory loss. And this is not to blame primary care, because it's hard to make diagnoses accurately earlier on. It's much more than about a blood test or a cognitive test being administered. There needs to be good information gathered about the symptoms and the course of symptoms. There is cognitive testing, there's usually imaging, there's neurologic examination in order to have an accurate diagnosis. And when we think about primary care and just how many conditions these physicians need to know something about, this is really difficult. So it's not to blame the physicians, it is a system-related issue. These diagnoses take time, they take skill, and ideally it takes a multidisciplinary team as well. Next slide. So what happens in usual care in Canada is when a family physician identifies a person who might have memory problems, they are sent to specialists. One study suggests 82% of the time. A provincial evaluation suggests 100% of the time they're sent to specialists. And this is not sustainable because we don't have enough specialists that do dementia care in Canada. The estimates are about 25 cognitive neurologists, 376 geriatricians, 187 geriatric psychiatrists. This is for all of Canada. And as a result of this tendency to refer, the wait times are now increasingly, very long. In some places, a year or 2 years before people can see a specialist for a diagnosis. So the diagnoses are made late, and care experience for people is fragmented. For those living in rural and remote areas, it means travel to the big cities and a long wait as well to be able to get a diagnosis. And again, not to fault the specialists, they're doing everything they can. It's just there's not enough specialists. Next slide. So that inspired the creation of the Mint Memory Clinic, a solution to build capacity at the primary care level, as well as build capacity at the specialist level. Essentially, it's developing a skilled team in the primary care setting that can do much more through standardized, nationally accredited training. We enable primary care to be able to diagnose accurately and manage people with memory problems without need for direct specialist referral in 90% of cases. In 10% of the cases, which are the most complex, there's partnerships with specialists who can help us with this, but in many cases can be done virtually or via telemedicine because the assessments that are done in the Mint Clinic are so comprehensive. These primary care memory clinics embed the expertise of family medicines, nursing, nurse practitioners, social workers, pharmacists, occupational therapists, and in many cases, Alzheimer's Society team members. Most of the Mint clinics across Canada have Alzheimer's Society team members embedded, in some cases, home acuity care supports. So it's a comprehensive assessment people get, and they get ongoing care. It's not a one-off thing. It's working with the family physician that people and their family members have full service access in their own communities with the most complex of cases, leveraging our specialist expertise, often through telemedicine, the capacity building so that only the most necessary are requiring specialist input, most can be handled in the primary care setting. Next slide. This is the difference in care. So in usual care, a person may identify memory problems, or the family member might identify that. They present to the family doctor. Usually they get sent to specialists. Most of the time they do. There's often a wait, a long wait, and for many, travel distance. The specialist will be able to provide that diagnosis, but often will hand back to the family doctor the remainder of care. And that leaves primary care and the person and their families to navigate a very complex system. With mid-clinic care, people living with memory problems and their care partners will present to their family doc. They get sent to their local memory clinic. The wait times are short. It's usually in the family doctor's office, so it's not much travel distance, and they get the diagnosis and they get the support they need ongoing. They get medication optimization, lifestyle interventions, help with navigating the system, getting the service and supports they need in a shared care model with their family doc. And just 10% of the time, there is a reach out to specialists, and often it can be done virtually. Next slide. The team members really do depend on the availability in the setting. I would say that of the 130 sites, every team looks a little different. It depends on which disciplines are available. So usually there's physicians, nurse practitioners, there can be nurses, pharmacists, social workers, and more. And as I say, Alzheimer's Society team members are usually embedded as well. Next slide. The care experience for people living with dementia and their family members is of timely access to a highly skilled team of healthcare professionals who know them and continue to follow along and address all of their needs. It's publicly funded. And most importantly, it's this proactive orientation, getting the services and supports a person might need to try to avert healthcare destabilization, to keep as much as possible people from needing the emergency departments and hospitalizations, the ability to live at home with their best quality of life for as long as possible. And it's about seamless, coordinated care throughout. Next slide. The training that we do is nationally accredited through the College of Family Physicians of Canada. It's been that way for more than 15 years. It's 3 days of case-based training that is delivered virtually across Canada, and 2 days of on-site discipline to discipline mentorship, just to make sure that the team is fully operational and ready to go. And we build the specialist support in for each site. And every year we have annual education updates where the best practices are shared and new tools and new updates are given. This year, we just finished this. This year, we integrated the appropriate use of the new blood biomarkers in the right cases. And also, we're working on pathways to some of these newer treatments. So it's about making sure that all teams stay up to date and are delivering the best care possible for people in their community. Next slide. So to sum up, the mid-memory clinic model is all about enabling primary care to diagnose and manage early stage memory loss, and also people with dementia without reliance on referrals to specialists for 90% of people. For the 10% that are most complex, being able to reach out to specialists in a timely way, such that the experience for people with memory problems and their family members is of comprehensive, one-stop, full-service care available within their own communities. And for the healthcare system, evidence of significant cost savings and positive healthcare system impacts, which I'll let Sana describe.
So in 2019, the Ontario Ministry of Health took notice of this model, and they commissioned an independent evaluation of mid-memory clinics by using publicly funded administrative health data to assess the impact of mid-memory clinic care compared to usual dementia care. and we are so happy to report that the results were substantial. From the time of diagnosis until death, patients receiving Mint Clinic care experienced a 38% reduction in overall healthcare system costs. There was a 54% reduction in inpatient hospital costs and a 51% reduction in emergency department costs. Importantly, specialist referral rates were reduced by 90%, meaning that the majority of care was appropriately managed within primary care. And this ultimately improves access while reducing the bottlenecks that we so frequently see in healthcare systems. The Mint memory model also impacts the transition to long-term care. And this provincial evaluation found that Mint care actually delays transition by an average of nearly 6 months into long-term care, which is quite substantial and supports aging at home. The value of these findings is that they don't just reflect financial savings, which are obviously great, but they also demonstrate measurable gains in system efficiency and improved coordination of patient-centered care. Next slide, please. In addition to the provincial evaluation, there was a cost utility analysis of the Mint Memory Clinic model that was published in BMJ Open in 2023. The study was led by University of Waterloo health economist Dr. William Wong, and he demonstrated that patients receiving Mint Memory Clinic care experienced an average overall cost savings of approximately $51,500 over the course of their illness compared to usual care, while also showing improvements in quality of life measures. In health economics terms, Mint is a dominant model, which means that it's an intervention that results in better outcomes at lower costs. And as you can imagine, that is incredibly rare in healthcare transformation initiatives. We've also consistently seen high patient and care partner satisfaction. So in earlier evaluations, there was a 96% of patients and care partners reported that they would recommend the Mint Clinic model to others. When viewed through the lens of the quintuple aim, which is a framework that guides healthcare systems all over the world, but especially across Ontario and other provinces, Mint advances all 5 domains, demonstrating that the model works at both the higher system level and the individual lived experience level. Next slide, please. Canada faces well-recognized system pressures. We have a rapidly aging population, increasing prevalence of dementia, limited specialist capacity, and growing strain on emergency departments and long-term care. So the policy question here is not whether demand will grow. We know it will, and we're seeing these trends internationally in comparable health systems. The policy question is, how do we plan to manage this growth sustainably? The Mint Memory Clinic model embeds dementia expertise directly into primary care. It extends specialist reach through structured collaboration, and it standardizes diagnostic and management pathways to solve these policy issues. Because Mint builds on existing infrastructure, it's scalable across urban, rural, and remote communities, meaning it has far reach across Canada and internationally. Every Mint expansion is co-designed with provincial and regional partners because we want to make sure that this initiative aligns with local resource capacities. And with that, I will pass this on to Dr. Michelle Casey.
Hello. So hi from the Miramichi area. I'm going to talk to you specifically about the Mint Clinic in Miramichi. This clinic was the first Mint clinic in the Atlantic provinces, and it's very well situated in Miramichi. Miramichi is one of the fastest aging community in the province, and as many of you know, New Brunswick is the fastest aging province in Canada. So needless to say, we do see a lot of people, and we do have a good number of referrals. Miramichi is a rural community with few programs and services. Although we're happy this is changing with the addition of new programs lately, so this is good news. I'm originally from a village close to Miramichi, but worked in Ontario for over a decade. This is where I had first successfully worked within a Mint clinic, and it was very, very clear to me that when I returned home to New Brunswick, I wanted to see a Mint clinic in this community where it's absolutely needed. with the combined effort of Dr. Lee and the Alzheimer's Society of New Brunswick, who has been extremely helpful. This first MINT clinic in the Atlantic provinces came to life. Next slide, please. The moving past challenges. So the MINT clinic in Miramichi is a bit different. It's currently located within a geriatric clinic in the Miramichi Hospital. So it's not within a family health team or a group of physicians. So this means currently we're supporting a very large area of New Brunswick in a resource low context. Currently, the team is myself, another physician, a nurse, and a first link from Alzheimer's Society, who's actually doing the caregiver interviews. So she's got a good role. Without the support from the Alzheimer's Society, this clinic couldn't continue, and we're extremely grateful to partner with them. There is a lot of changes on the horizon. So currently in New Brunswick, there's about 25% of the population without a family physician. So this is important to know. Primary care currently is working really hard and putting a lot of emphasis on creating family health teams across the province. This is a big change because the majority of physicians in New Brunswick still work solo and still works service. But the goal is to create these family health teams a little bit kind of like in Ontario, and then incorporate the MINT clinics within these family health teams. Currently, there's 4 MINT clinics in New Brunswick, and 2 of them are within a family health team. One of the other things that we are doing to help to create these MINT clinics is over a year ago, we've secured a new billing code for MINT clinics. So this is going to make it much more appealing for family physicians compared to the standard fee-for-service that was happening here in the province. I will leave it to Andriana for the next slide.
All right. Thank you. So I'm here from the Alzheimer's Society. So basically, a dementia diagnosis does not only affect cognition. We have learned that medical assessment alone is not enough, and individuals and families require education, emotional support, and practical planning. Within the MINT Clinic model in New Brunswick, the Alzheimer's Society serves as an integrated member of the MINT Clinic team, not simply as a referral partner. This means that when a person receives an assessment or diagnosis, they are connected immediately to community-based supports. So outside of care partner interviews, our role includes several key functions. So education, care partner support. So we offer counseling, support groups, individualized strategies to help families navigate behavioral changes, communication challenges, and long-term planning. And we also do ongoing follow-up. So, as you are aware, dementia is a progressive condition and needs change over time. So, we remain connected as circumstances evolve. The the MINT clinic model here in New Brunswick also supports connecting individuals and families to community services that extend beyond the clinical setting. So Nursing Home Without Walls is a community-based outreach program that supports older adults by offering social programs, wellness checks, system navigation, and practical assistance, helping individuals and families to remain independent and connected while living in their own homes. In Miramichi, Nursing Home Without Walls has been an incredible community partner, helping individuals living with dementia stay connected, supported, and active in their community while complementing the medical care provided through the MINT clinic. Next slide, please. Um, so while I have just spoken a little bit about the ASMB's role, I do just want to mention that the data that you're seeing right now are reflective of patient and caregiver satisfaction with the MINT Memory Clinic experience in Miramichi. So 44 patients and care partners responded to the survey, with 80% completing the survey in English and about 20% in French. Feedback was overwhelmingly positive, with nearly all responses rated as agree or strongly agree. participants shared that their questions were addressed and felt that the visit was a valuable addition to the regular primary care. And then to the last slide where I'm going to finish it off. Um, Lastly, we've just shared a few quotes from different family and care partners here in New Brunswick, and I thought I'd read one off. But basically, the staff have been a fantastic support to my father and myself. The care they provided us goes beyond expectations and has greatly improved my relationship with my dad. And as you see these quotes, you can really see and feel the support these Mint Clinic models has made here in New Brunswick. So thank you.
Perfect. So I want to say again, thank you very much to Dr. Lee, to Dr. Casey, to Michael, to Sana, and to Andriana, who have really kindly walked us through kind of what is the state of dementia care in Canada, why there's so many people who not only are living with the diagnosis, but many who are living without a diagnosis, the importance of a timely diagnosis and intervention, and how Mint Memory clinics are a real made in Canada solution to really harness, kind of the power of primary care in order to deliver that. So terrific in terms of walking us through, and then a real life example. I didn't know. Michelle and Adriana, that the Miramichi Clinic was the first one in Atlantic Canada, and now one of many in Atlantic Canada. So this is great. So as usual, we have an incredibly engaged audience who are already putting together a number of questions, which is terrific. If anybody does have additional questions they want to ask, please do put that in the Q&A box if you can, and we'll go through them, and I'll also invite our colleagues. They can look through the questions and type out answers as well, but we'll get through them. So first of all, one of the questions. So I'm going to kind of walk us through a little bit of a pattern through these, but one Sarah was asking. She said, working in a primary care clinic, I witnessed how family physicians apply cancer screening, counseling, as well as other chronic diseases, screening like for diabetes. Is there any policy to implement an annual cognitive screening in primary care, which is like, wouldn't it be as important as other screenings? And so I was going to ask, maybe Dr. Lee and or Dr. Casey, if you want to speak to that, because I know that there is some thoughts, or should people be annually screened for cognition, and maybe why that doesn't happen right now.
Sure, I can start, and then Michelle, feel free to build on what I say. To date, there have been no recommendations, like most consensus guidelines don't recommend screening for cognitive problems for lots of reasons, because there haven't been disease-modifying therapies until recent. There's been the concern about how would we handle a lot of false positives that people might get. There's so many things that can affect a person's memory besides neurodegenerative diseases. So there's been lots of reasons why there's been recommendations against screening, but I think all of us agree with the case finding, that is at the primary care level, looking for people who are at highest risk of having an undetected memory problem and applying screening tests. But also with the understanding it's much more than about a cognitive test or a blood test for that matter at this stage. It's about comprehensive assessment so that people know what they're dealing with if the result is concerning. Michelle, any thoughts to add to that?
No, I agree absolutely. I think one of the little cues that I've found in family medicine is almost that doorknob discussion, right? When people leave and they say, oh, by the way, I'm short of breath, I have this. But one of them that I've seen often in my practice is they just do something silly and say, oh, I've been forgetful, right? I'm forgetting, or they're going to do like a joke, but I think it's just things that needs to be taken seriously. And maybe if those things happen, is just to take the initiative and book a follow-up appointment and then discuss it a little bit further.
Perfect. Okay, and we've got the questions are pouring in. One of the questions is kind of a lot of process questions, and well, one of the questions first of all is before we get into the process pieces is one person saying, "Do you have any plans to expand this in Northern Territories?" Another question is asking about why aren't there any clinics in Quebec, for example, there, and then another person, Elizabeth, if we has asked, where are Mint clinics in Ontario? Is there a link? So if we do have a link, we should put that in our chat feature as well. But obviously there's a lot of excitement for these. Linda and anybody, or Linda, I'm going to ask you, and you can direct it to a member of the team who might be able to best answer, like why are there parts of Canada that don't have these clinics?
I'm going to ask Sana and Mike to answer that. Go ahead.
I'm happy to take that. So, we are a relatively small but mighty not-for-profit organization, and so we follow kind of a champion-led theory of change. So I think we are actively looking to see where we can develop partnerships in different areas of the country, as we would like for this model to be widespread across all of Canada if possible. So, the best thing that people can do to help with our efforts is to advocate to health authorities or policy and decision makers. And we're always happy to connect with people. I've thrown my email into the chat, but there's also we can share that as well. We're always happy to connect with people and assist with those sorts of efforts, because we really would like for this to be something that is across all of Canada.
Perfect.
Uh,
Go ahead, sorry.
I'll also add that we have a very robust wait list of clinics all across the country that are waiting for us to come and attend other clinics and conduct this training. So if you know anybody who is interested, who has the capacity to really identify those local champions, we'll have our emails presented at the end, and we would love to hear from you.
If I can also add, I think one of our challenges has been stable funding for training to cover the cost of training. We are not for profit, we are grant to grant, and where we're able to develop to have grants cover for training costs, that's where we train. In fact, Dr. Michelle Casey's site was trained with Public Health Agency of Canada grant funding. And so I think the ability to access grants helps us to be able to implement this more broadly.
Perfect. And if we do actually have a link to the Mint Memory Clinic map, I'll ask if someone could put that in the chat there. And people were saying, can I share this information with other people? You can share any of this with anybody. This is going to be recorded, and this will be on our website as well. So this is the goal of having this session today. It's just to raise awareness about the model, and also to spread the word as well. So there's some more process questions a bunch of process questions that are coming up. So one question from Sharon is, what characteristics would you see as part of the 10% referred to the specialists? So I'm going to ask if Dr. Casey or Dr. Lee might want to talk about, what are the folks that might need additional advice and support around?
Sure, I can start with that. So the people that are sent to specialists, we have worked this out with our specialists to support us. It is anything that is needing a specialist input, and usually complex diagnoses. It'd be when the presentation is unusual. Typically, it's the younger person who's presenting with memory symptoms. It may be existing other conditions that might affect memory, that might be complicating the diagnosis. It might be someone that's progressing more rapidly than expected. So there are certain types of dementias that we absolutely need a specialist confirmation of diagnosis. These would be cases like frontal temporal dementia or Lewy body dementia, where it's a little bit more complicated and there does need to be a specialist input. The management, though, is co-managed. So it's about accessing that diagnosis, making sure we're right about the diagnosis, and then being able to provide the care they need.
Perfect. And there's another question kind of related to this. It's saying, you've mentioned that the wait times, for diagnosis is about several months to a year. And I think that might be more in the general sense of kind of what wait times are. Because I appreciate that in the presentation we're talking about that MINT clinics are trying to get people seen in a more timely way, maybe 1 to 2 months or a matter of weeks to only a few months at most. So one question was, what strategies, tests, or tools can primary care providers do to help their patients that way? And so, I think it would be kind of more of the MINT memory clinic model. But are there any general things, maybe the team can say for those folks who say we don't have the team, we don't actually have these pieces in place, maybe, are there any other basic strategies one can do without a MINT memory clinic to at least start getting more timely diagnosis and management?
Michelle, did you want to take this?
Sure. I would say it depends on the type of group that you're working in, right? If you're a solo physician who doesn't have any allied health, I think it's just going to be taking the time to do it if this is really what you want to do. But now with family health teams, if there's a family health team who does not have a MINT clinic, but has a social worker or support or nurse, there are things that you could delegate to probably help to facilitate the process and help with the caregiver getting a bit of history and getting some cognitive testing done earlier on. Linda, I'll let you finish or complete if you want to add anything.
I think having an awareness that if people are noticing that they have some memory symptoms, and especially if their family members are noticing there's some memory symptoms, it's worth getting it sorted out. At minimum, accessing your primary care provider, looking for how can I get this sorted out? How can I get a timely diagnosis here?
Yeah, and I think the key point here is that many of the tools to get a timely diagnosis and management can be accomplished in a primary care setting, and so there is the training that the accredited training that people can get, so that people can feel confident in being able to make that early diagnosis and putting that initial treatment in place as well. So I've got a number of questions about the clinic process itself, for example. So Michelle and team, this someone said we're putting together primary care networks in place in BC. This seems like a logical place to develop a MINT clinic, where a rural community and access to specialists is even more difficult than in cities. What are the most important staff to onboard first to begin the process of development? Any suggestions for the beginning of the process? Now, hold there, because we'll see if anybody else wants to jump in. There's some other related questions. For example, Margaret was saying, for example, impressive initiative. Have you leveraged rehabilitation teams or professionals as part of the approach? And I did see in the list, occupational therapists, physiotherapists. There's another question looking at also asking about I think okay, I think those are the ones that were really talking about the team composition. So would love to hear any thoughts on that.
Sure. I can start with this. There does need to be someone that can work towards the diagnostic piece. So it usually is a family physician, or it can be a nurse practitioner. We have started to train some nurse practitioner-led teams, which I think really does improve the equity of access for those who don't have access to a family physician. So family physician, nurse practitioners for a diagnostic role, nurses can be nurse practitioners, can be help. Really, many different people can do the cognitive testing piece. Occupational therapy can do that. We have some sites where physiotherapists are involved as well in terms of administering various testing. There should be someone that can help with the caregiver piece. I did see one question about, is this just for the person, but how about the caregiver? Absolutely. It's always about more than one person. So someone that helps with the caregiver role, the assessment of caregiver stress at every visit, and also the service and supports that the family needs, this, the individual and the family. And someone to help with system navigation. And oftentimes that's the Alzheimer's Society team member, and often that person is doing more than one role. So it's a very fluid model in the sense of we can work with pretty much any healthcare professionals that are available, working as a team, taking on these various tasks.
That's perfect. There's some more process questions being asked about the Miramichi model, for example. So Kimberly was saying, I'd love to hear more about the model in Miramichi with how it's embedded in a hospital setting. What does it look like in terms of collaboration between geriatricians and primary care providers, or maybe other specialists? There's another related question from Jenny, who's asking, how does the funding model work? I heard that in MB there were billing codes. How does the model work, say, in the Ontario context? And another person, Catherine, was asking about the billing codes and again, just understanding a bit more about kind of the implementation model and if there are interprovincial differences that help or hinder implementation and feasibility. So I don't know, Michelle, if you want to first of all speak about maybe how that clinic is structured, and Adriana might have some thoughts as well about just that role. She very powerfully said the Alzheimer's Society is not here just as a referral receptor, for example, but an active partner. So maybe great to hear a little bit about the clinic a bit more. And then maybe we could talk a little bit about the funding models for these clinics with the billing code, but maybe, and Linda, Sana, and Michael might be able to give us a bit more context on funding and how does it work.
Absolutely. Well, I can speak about the Miramichi part for sure. So when I came to New Brunswick a few years ago, family health teams are existing, but they're not, it's really more starting. So what I've done is I've reached out to the Miramichi Hospital. There was 3 positions for geriatricians, and there was only one geriatrician there. So what I had done is asked if they would be willing to change one of those positions. It's a salaried position for a GP geriatric position. So that's how I was able to kind of step into the hospital, to the Miramichi Hospital, and start the Mint Clinic. Initially, when we started there, there was a nurse, an OT, we had a social worker, and the First Link from Alzheimer's Society all working together. But once again, because of resources, the OT and the social worker were moved to the floor. So we're working a little bit with the skeleton crew, but it's working still very, very well. We've learned to work great together. I don't think the model is made to be in a hospital. Well, it's not made to be in a hospital base, right? The communication with the geriatrician is very easy in this setting. For most of the time, we were sitting next to each other in the same office, right? So that communication was fabulous. We have a new geriatrician now who's there once a week virtually, but the communication is still great. We can just communicate by the phone, which is like most Mint clinics across the Canada is working, right? They're not sitting next to the geriatrician, but all the Mint clinics are supported by a geriatrician. And it's very easy to just text or call, and when you have questions, to communicate with your specialist. And honestly, it avoids a lot of referral. So out of that 10% that Dr. Lee had mentioned that is sometimes referred to a geriatrician, a lot of them can be discussed over the phone without necessarily having the patient to go see the geriatrician face to face. So that communication is a major part of the Mint Clinic. And communicating with family physician is going well as well. I think it's very important to all stay in touch and communicate together. The billing code for New Brunswick for the new billing code. So I'm salaried with this position, but eventually in the family health teams, it's going to be a sessional code. So it's an hourly fee. And somebody asked what that code is in New Brunswick. It's code 16. So if there's anybody from New Brunswick who's asking about that, that's that's the number to code for the hourly fee for the MINT clinics. I think the other questions is more related to Ontario or general, so I'll leave that to Dr. Lee, but if there's any other questions, I'm happy to answer.
Yeah, and I think, again, we have in the chat, Gemma, for example, has mentioned, thank you for mentioning to you, Dr. Casey, the social work role, right? Again, like all these roles are so important, in the clinic in terms of, again, the time involved. Joanna's noting that they have a clinical pharmacist, who accepts referrals as well. So again, how all those members can really speed up diagnosis, management, support, and it really does take a team. And I think that's the key goal. This is not about physicians only. This is about the team. But Adriana, before we go to Linda and Sandra to talk about other funding models, because it's a hodgepodge, across the country. But Adriana, do you want to speak a little bit more about the role the Alzheimer's Society plays? Because, again, some people would just say, oh, we just make a referral. But what's the additional support or role, within that clinic model?
No, that's great. I'm happy to share a little bit. So, here in New Brunswick, like I said, they're actually housed in the MINT clinic. So we have a first line coordinator from the Alzheimer's Society of New Brunswick who's actually located in the MINT clinic Monday to Friday. Um, so they take part in the care partner interviews, which is part of the MINT clinic model. But outside of that, they have the opportunity to meet all clients as they're coming in to the MINT clinic, and then we provide more of that emotional community support as well as different programming and care planning. So again, this is really based on family dynamics, families. We take a person-centered approach, so it's based on families' personal wishes and I guess what they would like to see for themselves in the future. So again, we can support people living in homes for as long as they would like to, or if someone knows they would like an individual to go to long-term care, we can support with those processes and system navigation. But the main point is those constant kind of not constant, but those ongoing touch points, because as needs change, it prevents families from having to reach out and find the answers. We are automatically reaching out, checking in, seeing how things are going, and then connecting them to whatever services is needed at that time. So that's kind of what we do here at the MINT Clinic. And I could go on, but I'm running out of time. I'm sorry.
No, and and it's actually a good thing. We're running out of time. We have 2 minutes left. So I'm going to ask Sana and Linda maybe to any other thoughts on how these models can be funded or the funding situation. It's exciting. There's a billing code and there's some further options in New Brunswick, but anything else that you want to shed light on before we wrap up?
I can actually jump in
Sure.
really
Thanks, Mike.
quickly, just while we've got a little 1 minute left. So we are, as a not-for-profit, we do the training and the capacity building, and so the funding that we get, typically it's been historically from grant funding and other sources of funding, and that is cost recovery for the training time and for coordination and the implementation, evaluation, all that kind of stuff. At the actual clinic level, clinics are actually operated independently. So they're operated by the primary healthcare organization that they operate out of. And so it's maybe too complicated to talk about the diversity, but it is very diverse how these funding models exist, even within the province of Ontario. I mean, if a clinic is operating out of a family health team compared to a community health center, compared to a secondary or tertiary healthcare organization, it will be quite variable, and the compensation for physicians and allied health will depend on that. In the long term, however, the ideal is what's happened in New Brunswick, which is the long-term sustainability of the funding for the clinics, which includes specific billing codes for this kind of work. If somebody has other questions, happy to connect on that separately.
Perfect. And thank you, Michael. And but thank you as well to Michelle, to Linda, to Sana, to Adriana for just really being a part of this talk today, so that we could, again, really talk about what are creative and innovative ways that are occurring to try and better support people living with dementia to get a timely diagnosis and access to timely interventions as well. So it's incredible that you were able to spend the time with us just to enlighten us in terms of how this clinic that started just 2 decades ago is now there's 130 plus, across the country, and there was momentum growing. So we want to share with people what this model was, better understand this. These processes. And as we said, if you have any further questions, you can always reach out to the NIA. Our information's on the left side here as well, and including how you can stay connected with us on social media, but also in the white space here, you've got the information to connect and learn more about the Mint Memory Clinic at mintmemory.ca. You can follow them on social media, and you also have a connection to Michael as well if you have any further questions or looking for more information as well. So thank you again for joining us. In the chat, you'll have seen other upcoming webinars that we have that we're hosting, and also a link to the NIA's Small Steps Big Difference.ca website, which really reminds us all about the things that we can do to prevent or delay the onset of dementia as well. So lots to think about, and but thank you again to my colleagues for really helping us kind of set this year's series off, where we're really starting to hone in when we think about the state of dementia in Canada, about the state of our care systems and our care providers. And it's great to see and promote, an incredible Made in Canada model that needs to be in every community as soon as possible. So I will leave it with that to say thank you again, and thank you to everyone in the audience who joined us, and have a good rest of your day.